Hi, everyone. My name is Anup Brahman. I'm a family medicine resident here at Columbia University. That's right, we do have family medicine here in New York. And I'm going to give a short talk here on tremors in primary care. I know it looks a little bit by my handwriting like I have a tremor, but I am working on it. Just a short preamble before we jump into the talk. So this lecture is actually part of a larger series of lectures on high yield primary care topics, and it's geared towards newbies in medicine, so med students, interns, new PAs or NPs. So if you do find it helpful, I hope you check out the website in the bottom right hand corner of the screen, shamanpreceptor.com. All right, so with that out of the way, let's jump into the case. So we have a 66-year-old female with a chief complaint of her hand shaking. So if you're anything like I was in med school, the only thing you really knew about tremors were the big buzzwords, the big P's: Parkinson's, pill rolling tremor, and that for some tremors, propranolol helped. And that was really about it. And obviously, if you're going to take care of a patient like this, you need to have a more robust framework. So before we can jump in and ask our patient a bunch of questions, it's important that we have a good differential diagnosis. So I like to break up tremors into their three big categories. So there's resting tremor. And resting tremor is the person's hands resting on their thighs, not against gravity, and checking to see if they have a tremor like that. Postural tremor, that'll be with the patient's hands extended against gravity, checking to see if they have a tremor. And then there's intention tremor. And that's also known as kinetic tremor. So for resting tremor, the big one you don't want to miss is Parkinson's. Another one that goes in the category is drug-induced. And then the last one is a bit of a zebra. It's Wilson's disease. Can present as resting tremor. Postural tremor, the most popular type is physiologic. So that's when regular folks are too caffeinated or sleep deprived, and a postural tremor emerges. Another very popular tremor is essential tremor. And then finally, there's alcohol withdrawal, which I'm sure you've already seen the tremor that you could get with alcohol withdrawal on the wards. With intention tremor, this is really a marker of cerebellar disease. Could mean that the patient has midbrain stroke, or it could be a marker of MS. So with that all in mind, we can start asking our patients some questions. So I like to take the mnemonic OPQRST that we normally reserve for sort of characterizing a patient's pain and use it for tremors. So in this case, we have onset. Did this happen gradually or suddenly? If it happened suddenly, that's less likely to be something like Parkinson's or essential tremor, but more likely to be something that's drug-induced. P is obviously provocative or palliative. And I'm really interested when I ask this question, does alcohol help? If it does, that's much more consistent with essential tremor or alcohol withdrawal. Quality, this is just asking the patient to sort of characterize the tremor in their own words. R is for radiation or better distribution in this case. So what I'm interested in here is, does it affect the legs? Does it affect the tongue? And these two, that's more consistent with Parkinson's. I want to know if it affects the voice. That's consistent with essential tremor. And I want to know about symmetry. If it's symmetric, it's more likely to be an essential tremor. S is just severity, so how much does this affect the patient's life? And then T is for timing. And then, of course, to round out your HPI, you're going to want to ask questions about, med history, social history, and, of course, family history. So for med history, we're concerned about antipsychotics or stimulants. For social history, you want to ask about alcohol. And then for family history, about 15% of the time that can be associated with Parkinson's, and about 50% of the time you'll see it associated with essential tremor. So with all this in mind, we can start talking about the physical exam. So physical exam. So for patients with tremors, the first thing you want to do is just see them at rest with their hands on their thighs, supported against gravity. Then you want them to extend their hands. After these two big things, you want to just do a quick neuro exam, in particular check cerebellar function, so finger, nose, finger, and heel to shin, and gait. After this, you could do some more specific testing, so we could look at their handwriting to check for micrographia, and you can also have them draw spirals. So if you find that their spirals are big and coarse, that's more consistent with essential tremor. And then finally, something that you want to look at is just to get a sense of how much this is affecting their life. You could just see them, drinking from a cup. If they're not able to do that, that's something that you have to act on sooner than later. And so after the physical exam, a few labs or studies that you might want to do, they're usually directed based off of what you gain from the HPI and PE, but for most of these patients, you're going to want to get a TSH just to rule out hyperthyroidism. And then what you'll also want to do, if you believe that our patient, for example, has essential tremor, then you'll want to get an EKG. And we'll get into why in just a moment. Okay, so finally, we're going to want to talk about treatment. So if the patient has Parkinson's, based off of your exam, you should refer them to neuro. If you find that they have essential tremor, then there's a few things that you can do in the primary care setting first. First, there's propranolol. So what you should know about propranolol is it's about 50% effective. So you should see it work for about half the time. You should know their side effects. So it is a beta blocker. So it can cause fatigue. It can cause erectile dysfunction in some patients, and you want to forewarn them on that. And then contraindications. So relative contraindications for propranolol are heart block. So that's why we get the EKG before we prescribe propranolol. And type 1 diabetes, because it can mask hypoglycemia, and asthma is a relative contraindication. Another med that's less well known for some reason is primidone. Now, primidone is a barbiturate. So side effects are sedation and sometimes even confusion. And so you go slowly with this medicine. You start off at 25 milligrams and then slowly titrate up to 250 milligrams which is where you'll start seeing the effects of this medicine therapeutically on the tremor, and you could go all the way up to 750 milligrams if necessary. In addition to this, a few things that you should also consider doing for your patient is an OT referral. So for many of these patients with essential tremor, they might have difficulty eating, and so having access to weighted utensils would be helpful. Having a phone that's easier to dial could be helpful. And so that's what OT can help with. And then, of course, if after propranolol and primidone and OT things aren't working for your patient, you can refer them to neuro. And neuro will try other meds like benzos, and they may even refer the patient to deep brain stimulation as a last resort. So that's basically all you need to know about tremor and essential tremor in the primary care setting. There's some great resources that you can also find at shamanpreceptor.com, some of the references for this talk. And of course, if you have any questions, love to hear your comments. All right. Thanks a lot for listening.